Let's get on. Okay. All right, Dennis, let me know when you are good. All right. Um, all right. All right. We should be good to go live in 30 seconds. Good.
It says live though here.
All right. Um, Good afternoon, ladies and gentlemen. Welcome to episode 3 of the Fleri Care Digest. My name is Sam Badu, CEO of Fleri, and today I have a very special friend with me, Tapiwa Virima, who is Managing Director of Diaspora Meds. Um, Tapiwa has a very special relationship that I hold dear, given that you know one of my daughters is also Zimbabwean, and he has such a great heart for the country. Tapiwa, maybe you'll start by introducing yourself, but it's a pleasure to have you here.
Thank you very much, Sam, and thank you very much to our guests and our viewers as well. As you've already mentioned, my name is Tapiwa Virima. I'm the Managing Director of Diaspora Meds. Diaspora Meds is an Afro-global medical insurance broking entity that is domiciled in South Africa and also in the UK. We distribute medical insurance solutions for Zimbabweans living across the globe. And to enable Zimbabweans across the globe to be able to give their loved ones access to private medical health care by paying from anywhere in the world, while their loved ones enjoy private medical health care back home in Zimbabwe.
All right, Tapiwa, thank you for that. But before we get into the serious stuff, I wanted to start maybe on the surface, right? You know, you grew up somewhere, you've had experiences living abroad. There's a reason why you started a company. Let's talk a little bit more about that. Um, Dig into your background and how you ended up, with Diaspora Meds and starting this.
Okay, that's a pertinent question. Thank you, Sam. It's a good icebreaker as well. I think growing up, obviously being Zimbabwean and growing up in Zimbabwe, you are obviously privy to a lot of, the plethora of the healthcare industry in the country. Basically, there's two gaps. There's the north and the south gap, and there's two extremes. There's access to private medical healthcare, and then there's access to public healthcare, which is supposedly free to some extent, but however, private medical healthcare is very expensive. There's a notion or a myth that says that there's the state of private medical healthcare is bad in Zimbabwe, but then growing up, you get to find that it's not a bad state. It's only about the cost of private medical healthcare, and if you can afford it, you can then be able to have access to private medical healthcare. But I think with the with the way in which the country has developed over time and a lot of immigrants living across the country now and always migrating away from the country, I think it is estimated that about 5 million Zimbabweans are living outside the country. With this, you find that all these Zimbabweans are sending back money, back home to cater for the healthcare needs of their loved ones because of the dilapidated state of the public healthcare system. And they're trying to give their loved ones the best of private medical healthcare, which is quite an exorbitant cost. I think synergizing this plethora of bad medical healthcare and at the same time the amount of money which is being sent back home, we found that we're trying to come up with a solution that can enable private medical healthcare to be easily accessible at a cost that is, affordable to everyone. At the same time, enabling the diaspora to be able to cheaply support their loved ones back home. I think this is sort of the nexus where we came through and how Diaspora Meds was born.
Really appreciate the context. For a lot of people, certainly from my background, we usually think of the continent in a sense where there's where we come from regionally that we really understand. For West Africans, that will be the ECOWAS region. But a lot of people who are West African probably don't even have a lot of insight into how medical insurance in Southern Africa really works. I wanted to start by asking about, how medical aid works, and for me, the biggest part was the realization most recently at a conference in South Africa that less than 10% of the Zimbabwean population has access to medical aid, right? Something that was made to be more affordable and generally available for everybody. Talk a little bit about medical aid, the context within Zimbabwe, the unique landscape that we find ourselves in when it comes to that particular country, and how for you you realize that there was an opportunity to correct the gap before we get in.
Okay. So just to give you a bit of context around the Zimbabwean market with respect to medical aid, traditionally, it's been a privilege of corporate individuals. You find that in many instances, medical aid companies or medical insurance companies would only take large corporates, whereupon the employer embeds the benefit of medical aid onto the employment package that they give the employees. In that respect as well, medical aid societies and companies have vetted themselves against the risk of taking individuals that were walk-in clients and would be high risk because they would just walk in at the instance of the fact that they felt that they were sick and they would go and insure themselves. So largely there was preference for corporates, big corporates that would come in. Maybe a single bank would employ or would insure all its 200 employees, or a mining entity to insure 1,000 employees on medical aid. Medical aid is such a big appetite for those. However, with time as well, as people would retire, you find that pensioners would also migrate to looking for medical aid because the benefit of medical aid would be rescinded at the instance of the employment contract being terminated for one reason or another. There was a growing consensus around the populace of pensioners requesting and needing medical aid in terms of continuity post the employment status. However, medical aid societies and companies did not likely have appetite for pensioners because of the risk that was associated with them. Naturally, the older you grow, the more risk you become from a health point of view. That also, with the unemployment rate that started to exacerbate in the country in Zimbabwe, you find that many people fell out of jobs but were in need of medical aid. And there was a large consideration of taking individuals on a medical aid, which was against the norm previously. In that instance as well, with the migration of people across the diaspora, you find that there was an appetite created for individual or the retail market around the medical aid, schemes. So just to come back to your point where you did mention that from the conference you attended, less than 10% of the population is on medical aid or insured by medical insurance. It is very true because that 10% actually ties down to the employment rate in the country, which is around about at the same rate at 10%. So you find that most of the insured people on medical aid are the people that are employed, and the unemployed people are largely not on medical aid. So that is the landscape of medical aid in Zimbabwe. So we have come into the gap to try and bridge in, number one, the unemployed, number two, the pensioners as well. Number three, just generally anyone who has to go on medical aid and doesn't have the capability or is not employed by anyone else. But this doesn't alienate the fact that we still have appetite for people that are in corporates as well.
That's a really key insight that you just shared, and I'd never really mapped up, the unemployment contribution to a lack of access. But it makes sense. If you don't have predictable income, you can't get a recurring insurance bill, which brings us to the unique value that Diaspora Med brings for Zimbabweans, and the reason why I thought it made so much sense for us to partner, right? Zimbabwe's diaspora is unique in a way. As a country, between 12 and 15 million, right? Almost the population of Lagos alone right? But at the same time, as far back as 2010, I believe, Zimbabwe crossed $2 billion in remittance receipts, which means that though you have fewer people in the diaspora, they're sending so much more money and there's so much more dependence on them. I want you to talk about at what point you realized that there was a connection between the mission that you wanted to solve and how you were actually going to fund that.
Okay, that's an interesting statistic that you've raised, Sam, with respect to the diaspora remittance and Zimbabwe's reliance on the diaspora. I think it's a well-known fact that Zimbabwe largely relies on the diaspora, and the annual remittances range anything between 1.5 billion to 2 billion on a yearly basis, and it's estimated that just between 8 to 10% of that amount is possibly on medical bills. Now, if you look at that, you are talking nothing less than 100 million US dollars sent for medical reasons back home in Zimbabwe. In that respect, you find that at any instance, it is more expensive to pay medical bills out of pocket than to be on medical aid. Medical aid or medical insurance is basically the pulling together of funds where individuals come together and risk is shared in a pool. And in that respect, the costs become cheaper because the risk is shared. So we then realized that we had a gap because some of the funds that were being sent towards medical reasons, number one, were either being misappropriated by relatives. There was misrepresentation largely from relatives, whereupon individuals would, would inflate the cost of medical procedures or medication just because the country was in a bit of a mayhem. Also, secondly, you find that there was a bit of malpractice from medical practitioners across the board, where they felt that as long as you had sustenance coming from the diaspora, there was always that capability for them to pay because they don't know how desperate the situation is on the ground. So, for example, if I have a relative on the ground and the doctor knows that this person is getting funded from the US, they would inflate the cost and take advantage of that situation. So you find that there was no gazetting of prices. So we felt that coming in to bring that linkage within the diaspora, where number one, funds are not misappropriated. Number two, we could also lower the contribution of sponsors outside the country and ensure that there was, efficient channeling of funds into the medical industry. At the same time, we felt that by coming into the industry, we would help the growth of the medical industry. Because we would actually promote an efficient system of channeling funds across the board. So I think this was a lot of motivation around those issues.
Yeah, I think that's very, very enlightening. And I want to stay on top of the insights primarily because you've done something that a lot of people haven't really done there. And I've on my most recent trip to Harare, I visited a number of hospitals. CMAS owns quite a number of facilities, and I look at how they're solving it, how you're approaching it, how others are also trying to solve the problem. I realized that regulation isn't supporting a focus on retail healthcare access. So everybody is trying to figure it out. Any government hospital that you go to, there's a shortage of doctors, there are long queues. Talk a little bit about how, Diaspora Meds helps organize the actual care coordination part of getting your family healthcare, because it's not enough to be able to send money, via Western Union for them. Like how they use the money becomes its own headache, right? How is Diaspora Meds supporting this? How are you thinking through the access, but also the coordination of care that they are accessing?
Okay. So what we've done is we've dubbed ourselves the home of health, firstly. And secondly, our brand promise to our clientele is to offer peace of mind. As we service clientele that are in different countries and miles away from their loved ones back home. So we firstly basically we've developed a model where we have a personal relationship with our sponsors and our beneficiaries on the ground. We also have a very sustainable and a very rewarding relationship with our service providers. So we have about 500 service providers across the country. And these service providers, they range from pharmacies to GPs to hospitals to specialists, laboratories, etc. In that respect, how we then coordinate is that we have a very robust education system around the use of our medical care. As we collect funds from our sponsors across the board, we place these funds with our underwriters in the country, this being Summit. We also then place funds with different reinsurers across the board, being Cigna Health and Swiss Re, just to ensure the sustainability of the fund. We then, I think you spoke about the issue of shortfalls, co-payments, etc. Our medical insurance has become a preferred medical insurance because of the USD element, and we give some sort of, reliability in terms of payment, as opposed to other medical aids on the ground that then pay maybe in RTGS or do not have reliability in terms of payment. We are collecting foreign currency, and we then ensure that our service providers are paid in foreign currency. We then ensure that our beneficiaries also get good service. So the first pillar of our relationship is a circular relationship between the beneficiaries, the sponsors, and the service providers on the ground, and the guarantee to be able to pay service providers in hard currency, which enables them to be able to provide services and products as well to our beneficiaries on the ground. We also have a constant engagement system with all the stakeholders involved to ensure that there's a feedback system where there's attendance to issues. We've got a 24-hour call center in Zimbabwe where we are able to attend to emergencies, and also a 24-hour client relationship management system where each individual is allocated a client relationship manager, and they can be able to speak to those on a daily basis. We've got wellness programs that we run as well that are over and above just the medical aid in itself. So basically, from an access point of view, we try to be in every remote area, every major town, every city, every growth point. I think we've got a good engagement process where we also book appointments for our clients in terms of accessing doctors. We book appointments for our clients in terms of accessing medication. So we've tried to differentiate ourselves from the traditional medical aid where you join, you pay. After you pay, there's no relationship with the medical aid. You only go and access your medication. You go see the doctor. If it declines, you walk into the office and find out after 2 days and 3 days. So we've tried to personalize the relationship across the board. And I think that has made us a little bit more different as well. But moreover, the efficient allocation of resources as we collect resources across the world and we deploy these resources into the medical system in Zimbabwe efficiently, where there's no fraud involved, where doctors are not misquoting, where medication is not being overcharged, where parents are also not misrepresenting to their children that they need medication funds and they don't need medication funds. But I think that's basically it, sir.
Yeah, Tapiwa, I really appreciate the dig into it, and I want to because there are a lot of Zimbabweans that are listening to this, and also because the video is going to go up on YouTube, I want to be able to address some of the real issues that happen on the ground. For instance, the way that you handle shortfalls, right? The way that you handle doctors inflating the cost of care, where someone pays for the insurance, they get to the hospital and they realize that the doctor is saying you have to bring $20 to be able to co-pay for this session, right? Otherwise it's not going to be covered. How are you addressing some of those concerns that Zimbabweans in the diaspora might have when they're considering purchasing a plan on Fleri from Diaspora Meds?
Okay, shortfalls is a very big issue in medical aid and medical insurance. With respect to shortfalls, maybe let me explain how shortfalls arise. So firstly, the medical insurance is governed by a body called AFOS. AFOS is called the Association of Funders of Healthcare Providers in Zimbabwe. AFOS is the governing body for all medical aids as well as service providers who happen to be doctors, pharmacies, and any other hospitals that come through. So they gazette prices and they standardize the charge for a standard GP consultation, for a particular medication, for one night in hospital, for a specialist. So the medical aid always tries to match against that. And when the medical aid tries to match against that, you find that in an ideal world, there are no shortfalls and co-payments. However, you then find that what happens is that shortfalls may arise whereupon they try and meet their cost outside the scope of medical aid, and they are running a business and they feel that maybe they have not made enough money. They spike the prices up, and they are not exactly out of regulation by doing that. So sometimes you find that this is when medical service providers act out of contract from medical aid and medical societies. However, we do engage them and we put them to the sword, and we take them back to the contract where we say shortfalls and co-payments have arisen. And this is the negotiation that we then come through and we negotiate on behalf of our clients. However, there are also instances where shortfalls arise when people are accessing medication. The landscape of accessing medication in Zimbabwe is that for locally produced drugs, you find that from a comparative advantage, the drugs tend to be cheaper. However, when drugs are not available in the country and they have to be imported from, say, Turkey, India, South Africa, or wherever they're imported from, the costs may go slightly above what the natural costs are in most instances. In that instance, you find that there's a disparity between the gap of what is the price where that was gazetted by AFOS and that the medical aid pays vis-a-vis the cost in which the pharmacies obtained the drugs. Talking about hospitals in many instances, the inflation of prices happened during COVID because it was a question of demand where people were competing for beds in hospitals. You then find that hospitals started to charge above normal prices because they felt that they could make more money, so they were basically profiteering, which was against the law. And it took time for hospitals to adjust against this. However, the advantage of medical aid or our medical insurance and how we deal with this is that we've got an upfront agreement with service providers, particularly those on our list, with respect to the gazetting of prices. And you find that because we've got gazetted prices, which are matched with hard currency prices on our medical aid, there's barely, I would like to say there's minimal to zero shortfalls and co-payments. And it's important to underline that there's minimal to zero shortfalls and co-payments because there are instances where a service provider tries to justify why they are charging a price above the gazetted price on the pretext of the issues that I've highlighted, prior to this. So there is minimal to zero shortfalls and co-payments. They may happen in certain instances, but in most instances, they do not happen.
Yeah, really, really appreciate you breaking that down because it's a question that comes up over and over again every time we talk to community or we speak to someone, and then even on the ground, right? Because I still have friends and relatives there on that side. But as you talk about the plans and the way that you operate. I want to be able to reiterate back to viewers and then the audience. At the end of the day, what kind of outputs or what kind of goals is Diaspora Med trying to meet? Right. I want to say, take a look at CMAS, take a look at any of the other mutuals that are available, right? How do we differentiate Diaspora Meds, your agenda, the mission, from what everybody else is pursuing, right? And how do we make sure that as folks are listening, they understand one more detail that really lets you stand apart from the others that they will encounter on the exchange itself?
Okay. So Sam, the issue is with Diaspora Meds, we are there to provide the bridge of first world healthcare to a third world country. And we are there to bridge and close the gaps that exist. Dealing with a population of 5 million diasporans living across the country, they've had access to some of the best medical care, and they wish the same for their loved ones back home. Our job is to mirror the service care that is being provided or that you're accessing in the diaspora, so that your parents and your loved ones can be able to access something close to what you're accessing. There's nothing as disgruntling as living thousands of miles away from home and you don't know the service quality or the quality of medication or medical services that your loved ones get back home. whilst many medical aids and many medical insurances are in business just to ensure that they collect premiums and people get access to medical care as and when they can, our job is to ensure that someone living thousands of miles has got peace of mind knowing that we walk the healthcare journey with their loved ones. We are the home of health, and our brand promise is to provide peace of mind. So we walk the healthcare journey. We are there to broker and ensure that your loved ones get the best of healthcare by referring them and ensuring that we book them in the best of hospitals. We ensure that they get the requisite medication that they need to get. We are there to ensure that they go to a qualified GP. We are there to ensure that the specialist that sees them is a qualified specialist who gives report backs, and you can be able to be accountable for the health care of your loved ones. Being miles away from home and failing to engage a service provider, you may only be able to get a report back from an ailing parent or a patient or a parent who is now old, and you don't get a comprehensive report, and things get so bad and you don't know what's happening. So for us, it's more than being able to collect a premium and allocating it and paying for the services that your loved ones can access back home. It goes beyond that. It's walking the healthcare journey with all our stakeholders. And this healthcare journey is enabling that we know that we walk from point A to point Z, and we save the lives of our the lives of our patients and our beneficiaries. So we're not here to see people pay premiums and then they access medical health care. When they die, they die. It's the healthcare journey that we need to be able to work with people. And that's what we've done for a lot of our clients. And that's why we've become the preferred home of health for many Zimbabweans living across the globe, because it's that thing that differentiates us to be able to walk the healthcare journey with everyone.
Yeah, really, really appreciate that. There are two more questions that I want to touch on before we even wrap up. But obviously, you're here for a reason, right? From the first time that we were connected and started talking, there was something really special about the way that you saw the situation of care. Some of the stories today I posted, the story of a friend of mine, Tinashe, that I put up, right, living in the UK and literally crying because his mother was back in Zimbabwe, being sent from hospital to hospital. And like, you have to be there to see it, right? You're trying to catch a cab and the cab is taking you, and then you're trying to catch another cab because you go there, there's a long line, you're leaving, and you can't do anything about it, right? Because you're in the UK, no matter how much you're being paid, you're literally helpless trying to navigate this. And I think for me personally, at Fleri, we constantly think about there are lots of people who have passion, a lot of people who have courage to pursue hard problems. How do we elevate them? How do we make them more available, more visible for people to see? Hence the Fleri Health Marketplace and all of the partners that today we're working with. But I wanted you to talk about the partnership from your perspective, right? As a company that's providing care, from your perspective as an entrepreneur who's trying to solve a problem. How is Fleri helping you pursue this? What is the opportunity that you see for growth with the partnership on that end?
Okay, Sam. Fleri to us is a very strategic partnership. I think we have a lot of common ground, a lot of common goals, a lot of consensus around our mandate. And what brings us together first and foremost is the fact that they say that coming together is the beginning and working together is a forever. So for us and Fleri, I think our common goal is that we've put our communities before ourselves, and we've identified that we need to alleviate the healthcare gap in Africa. And we love the work that you have done across the globe and the access to market that you have given many healthcare providers, at the same time ensuring that you provide care beyond borders for many institutions. So I think Diaspora Meds is a natural plug-in into Fleri, and I see a lot of scope because of our exchange programs that we do have between ourselves and Fleri in terms of access. We both share comparative advantage in different markets, and you as Fleri, you offer a platform for visibility for Diaspora Meds, for particularly Zimbabweans living in the US and other parts of the world, to be able to see and to be able to access private medical health care and other care that is medical related. And for us as well, I think it's a collaborative activity, because as we see more, we see mileage into Africa, we see ourselves being able to put and increase our footprint and change the lives of our people. I think I see Fleri as a marketplace for healthcare, basically where people can be able to interact and have different options and access the best of medical healthcare and make good choices in an interactive society. So for us, Fleri is a very strategic partnership. We see ourselves going further into Africa and increasing our footprint with yourselves and being able to change the landscape of medical service provision in Africa. I think with our joint efforts, at some point in our lifetime, we should be able to see Africa healthcare migrating towards the standard of first world healthcare. It will take time, but I think we'll get there.
Yeah, I think the best time to plant a tree was 10 years ago, and then the next is now, right?
Yeah.
And for us, as we continue to discover, highlight, and appreciate the work that folks like yourself have been doing within the communities and even supporting the communities outside, that will continue to be the mission in driving that. I wanted to go on and actually run through the plans that you have, so you can maybe talk about a couple of them, and talk about how people can access the plans, how the plans themselves are put together on that end, because I think that's very fundamental to the goals that we're trying to achieve at this point in time. So I'm going to share my screen and then walk us through a few of the plans on the exchange itself, just so that we have an appreciation for what does the money actually get you when you have a family member that you're sharing that with.
Okay.
Yeah. So I'll pull up for Zimbabwe. When say for Ghana is always trying to get in the way of Zim, but we'll let it. When we get into the plans, maybe we'll start with the Manuka, and then we'll look at a couple, right? So on the more affordable end, walk us through the Manuka plan. Walk us through how the plan is put together, what folks are getting for this plan.
Okay. So basically, we have three plans. We will discuss the plans comprehensively.
Yeah.
We have an entry-level plan called Manuka, a middle plan called Lavender, and a premium plan called Clover. Our plans are designed to give comprehensive healthcare around every individual. Let me hasten to mention that, number one, we do not have age restrictions on our medical aid, which means that we take people from birth until sunset. Our plans are divided into three, as I've already mentioned, and there's also further age segmentation of three categories. So the first age segmentation is 0 to 18, which is categorized as children and priced differently for risk profiling purposes. And the second age category is 19 to 64, which is categorized as adults. And the last age category is 65 plus, which is categorized as pensioners. So talking about the Manuka plan is designed as an entry-level plan for individuals that, from an entry-level affordability point of view, whereupon the charges start from $32 per child per month up to $60 for a pensioner. So the benefits that are on the Manuka plan start from your chronic medication to your acute medication to your GP consultations, to your dental benefits, to your optical benefits, pathology, and hospitalization. So on the Manuka plan, your annual, the $13,000 is your annual cover, which means that the individual draws down from the $13,000 on an annual basis. So in that respect, for example, there'll be $800 allocated on a yearly basis towards chronic medication. There will be about $700 allocated towards acute medication, acute medication being medication that you possibly need when you're either hospitalized or when you just fall sick and it's not chronic, or it's just not your over-the-counter drugs. There's also a hospitalization benefit of between 5,000 to 6,000 on an annual basis, and you've got optical benefits and dental benefits as well. There's an ambulance benefit on your Manuka plan, and also pathology tests and specialist allocations that are on your Manuka plan. So basically, to sum it all up, Sam, your Manuka plan is a comprehensive medical plan, and it's for those that are possibly still, young professionals entering the market wanting to support their loved ones back home, but from an affordability point of view, they possibly can't afford the premium cover and the middle level cover. But from a cover point of view, it does cover everything. It may just not cover from a financial point of view what the other two plans that cover that we'll speak about.
Yeah. That's really great. And I wanted to mention that it doesn't just cover on an individual basis, but you also have a family cover that takes more than one person, correct?
That's correct. So on a family basis, to avert anti-selection risk, we quote on the basis of the age provided and the individuals that is being put on a family. Because from an insurance point of view, the traditional family is father, mother, and kids. However, you find that with people having migrated to the diaspora, the family nucleus is destroyed, and thus the definition of a family is a little bit different. So there is bound to be anti-selection risk, where a family could mean a granny from the paternal side and granny from the maternal side, and then an aunt from there. So, but we do have family covers, and they are quoted on a case-by-case basis.
Okay.
Yeah.
Makes sense. We're looking at the Lavender plan right now as we look through, and I think, like you said, you immediately start to see that there are higher limits for the outpatient, dental, optical, and so while all of the plans that come under diaspora care cover the extent of treatments that an average person would need, including maternity, it's the limits to which they access those individual care needs that really changes based on affordability.
True. So it's based on affordability, and also we've seen over time that the determination of the decision making in terms of the cover selection is based on the underlying conditions that the individuals have. You find that individuals with high risk diseases or chronic conditions tend to go for the higher covers. This is to avert the risk of exhausting your benefits in the course of the year. So you find, for example, on Lavender, when an individual has one or more underlying conditions, take, for example, maybe they have high blood pressure and diabetes at the same time, they tend to go for cover such as Lavender, due to the fact that there's higher allocation of chronic medication, there's higher allocation of hospitalization benefit, and also any incidentals that may happen in the course of the year, an individual is comprehensively covered. And this averts the risk of our initial discussion surrounding shortfalls and co-payments, where you run the risk of exhausting your benefits during the year. So individuals with more underlying conditions tend to go for this. Also, we've seen a pattern of individuals where they've got aging parents or aging beneficiaries. They tend to go for the higher covers because of the risk profiling of from an age point of view.
Very, very good on there. And I wanted to ask, for the plan, regardless of the tier of cover, what does it look like being able to determine whether someone has a pre-existing condition or not, right? Because if, for instance, my mother is in Zimbabwe, but she's never really had consistent care, and now I hear about Diaspora Meds, I go to Fleri, I want to purchase the plan. Does my mom have to undergo any test to determine her pre-existing condition, and thus eligibility on that end? What does that look like?
Okay, so our medical aid does not discriminate on the basis of underlying conditions. So you find that the bulk of clients joining the medical aid are already privy to the underlying conditions that are there, because they've got a previous script from the doctor who's been attending to them prior to them joining the medical aid. Sometimes they're even migrating from one medical aid to the other. However, there are also instances where an individual is unsure as to the underlying conditions that the parent may have or that the beneficiary may have. And at that instance, they do request that we either help them to provide a doctor who can assess the underlying conditions, or they send them for a pre-examination prior to. While a pre-examination is not mandatory, as long as you are privy to some of the conditions. However, in instances where there is doubt, we do encourage members to do a pre-assessment to be able to get, sort of like a preview for planning purposes, because you may undersubscribe for the beneficiary, put them on a plan that doesn't suit the underlying conditions in question.
Yeah, that's a really, really good approach where essentially everybody is assessed to have it. And then if you believe that you're in exceptionally good health and without any underlying conditions, then you can submit, to a test that proves that that's lowering the cost of it. Really love the comprehensive take through each of the plans. Finally, I want to ask about what support looks like. You mentioned that you have a call center in Zimbabwe, but what does escalation, what does emergency support look like? When it comes to someone who you've now put on a Manuka, Lavender, or Clover plan with Diaspora Meds or for Fleri, and then you're trying to react to an emergency in that case.
Okay, great. Sorry, before I answer that question, may I just speak slightly about the Clover plan? I see we didn't speak about that one. It's our most important plan. Because it offers a international care in South Africa and India, when individual has been referred that the condition that they've been treated is not getting better in Zimbabwe, or there's no technical expertise for a particular condition. And also, besides that, besides the technical expertise, there may be issues around the fact that the individual has had a perpetuated disease that is not being, or there's no machinery around treating that. There's option that an individual goes to South Africa to be attended at Netcare group of hospitals or at Apollo group of hospitals in India. So it's our premium product that also gives access to the best of hospitals in Zimbabwe, bring your group A hospitals. And it gives more comprehensive cover, as it gives $33,000 a year. Right. I just thought I'd hasten to mention that, Sam, and then let me go to your question now with respect to escalation of, problem solving. So basically how our model is defined is that the entry level point is that we have a client relationship manager designated to every client. And the client relationship manager manages the relationship from an end-to-end point of view, where they engage the sponsor and they educate the sponsor on the medical insurance. The sponsor makes the decision as to what package to take. The client relationship manager helps the sponsor with the sign-on process. Once the sign-on process is done, the client relationship manager will engage the beneficiary back home in Zimbabwe, educate them on the medical aid, assist them with the collection of cards and biometric solutions and issuance of policies. And once that's done, they help them to be able to start to access services. Now, various emergencies arise where, for example, you've got emergency when an individual has to access services in the evening and it's an emergency service, and some hospitals are either closed or so there are emergency rooms around the country. So the client relationship manager is available 24/7, and also as an assistant who's available as and when they're not available, to be able to get a call rapidly from either the sponsor or the beneficiary. So the sponsor can call and say, my mother has got an emergency situation, can you help to book an ambulance? Additionally, the beneficiary back home is equipped with a toll-free number in Zimbabwe that they can call at any time, which is the 24/7 toll-free, which is supplied by our underwriter, Summit Health Fund. So basically, the beneficiary can toll-free call, and anyone who's supporting them in Zimbabwe can toll-free call and help them and request for emergency services. So basically, emergency services are normally around where people fall sick during the evening, or they need to be admitted at some hours of the night or something along those lines. So those are emergency services basically, or where during the day a beneficiary is failing to access service or trying to look for the closest service provider, or they need an agent approval at a hospital that may not be enlisted, or a doctor that may not be enlisted because they can't travel from one point to the other due to an emergency. So our client relationship management network plays a very important role in quickly resolving issues in terms of turnaround. But our call center is a backup plan. So we've got an end-to-end between the client relationship manager and the call center as well. So our beneficiaries and our sponsors have those options that are varied. But we try to be in every center from a service provider point of view so that people have got proxy providers very close to them.
That makes a lot of sense, and thank you so much for walking through that, because everything goes right until it doesn't, and that's when it creates an opportunity for people to get really flustered. And I want to make sure that as folks are listening in, they clearly understand that from the time they think about, hey, what could be going on, this actually allows us to be able to see how that works in all of its extent. Um, I really, really appreciate you taking the time to walk us through. Really appreciate um, making the time to be able to speak to it. And as more Zimbabweans come to discover and learn about what Diaspora Meds is doing, we want to continue to celebrate the work that you do, continue to push it, continue to tell more and more people about it, and just to continue seeing the growth from there. It's been a pleasure having you on here. I'll leave the last words to you before we sign off.
Thank you very much, Sam, for having me here. It's been such a good time discussing how we can give peace of mind to our diasporans living out there. I do encourage a lot of diasporans watching this to sign on to our medical insurance via our partners Fleri as well. As we try and change the landscape of medical service provision in Zimbabwe, and we offer you guaranteed peace of mind. And stop the problem of sending money back home for medical aid when we can take care of your loved ones back home. So I look forward to ourselves working with many Zimbabweans across the globe and working with yourselves to expand our footprint across the African continent and, changing the narrative on this continent in terms of the whole medical landscape.
Thank you very much. Thank you, Tapiwa. It's been a pleasure having you here. Looking forward to doing more work together and actually having an impact. I appreciate you very much. Thank you.
Thank you very much. Have a good evening.
All right.